Department. So, Dr. Sarah, thank you very much for volunteering and giving this very important lecture, I think, at this time. And we take this important thing from the reference for like this disease. Just to give, I think all the department, they know her, and all of our actually hospital, they know Dr. Sarah, but we have people are attending from outside of our hospital. So Dr. Sarah, she's associate professor. She's almost to be a professor, inshallah, within a few days in pediatrics, and she's a specialist in infectious disease. And also she's doing, she did a fellowship in infection control a few years back, or actually more than a few years, more than 10 years back. And she's part of the task force committee for the COVID in our administration in the hospital. تفضلي يا دكتورة سارة, welcome.
جزاك الله خير دكتور خالد. السلام عليكم جميعا. أتمنى أن الجميع بخير وصحة وسلامة إن شاء الله، وأتمنى أن احنا نعدي احنا والبلد نعدي الفترة الحرجة هذه بسلام وأمان بإذن الله.
إن شاء الله.
So, as you know, pandemic is not something new in history of humanity. Previous pandemics caused tremendous loss of life and numerous deaths. Most of the biggest one reported in history is the Black Death, which was caused by plague in 13th century, and it is the biggest number of deaths recorded, up to 200 million. Another pandemic also, which was reported, is the Spanish flu, which was in 1918, and that pandemic caused almost 50 million. Last pandemic that we came through is the H1N1 in 2009-2010, and likely the death which was reported during that time was 200,000 only. So everybody, even including the infectious disease expert, was expecting that the next pandemic would be actually a flu. And surprisingly, it happened with this new coronavirus. So as you know, the story started in WUHAN in China. WUHAN is actually one of the largest cities in central China. It has a population of 11 million. It is a major political, economic, financial, commercial, cultural, educational center of central China. And also, in addition to all of this, it is a major transportation hub there. What is interesting there is that also WUHAN has one of the highest level of viral labs, which is called WUHAN Institute of Virology, where they deal with lots of viruses, including coronavirus. That's just the basic background about where the outbreak actually started. So the first cases were actually reported in live animal.
Sorry, too much echo. The sound is not clear. Too much echo, really. Sound is not clear at all.
طيب. First of thing, kindly raise your hand, ya Ahmed. So, and I would like to ask all the people, they are muting their mics, but I think all of them, they mute. So the problem, I think, with your phone, ya Ahmed. Go ahead, Doctor.
Okay, so WUHAN has a big seafood market where there are not only seafood, they have multiple types of all animals, whatever you can imagine. They sell more than 120 types of animal, with including 75 species. They sell bats, dogs, big camels, snakes, and cattle, in addition to many other animals. And they were all, as you see, kept in cages above each other, very adjacent to each other. So that was really a big transmission hub. So what happened in December, the first case was actually reported in 9th of December. We don't know whether there were unknown or undiagnosed cases, which was reported prior to that. But the official report goes back to 9th of December, where they noted that they have multiple cases of pneumonias. When they trace those cases, they find that 2/3 of them, they got exposure to this seafood market. That's why initially the seafood market was thought to be the point where the transmission happened. samples. They took multiple samples of these seafood markets. Only 33 of almost 600 specimens were positive for SARS-CoV-2. When they did the viral sequencing for these isolates, 9 of them, they were 100% identical, and they were almost 80% resembling to the previous SARS virus, which happened in 2003. It also had a 50% similarity to MERS-CoV, which is endemic in our country. And it was thought that the bat is the reservoir for this virus. So for the naming of this virus, there is an international committee of taxonomy of viruses, which is the Corona study group. This is the committee that is responsible for naming of any new virus. They decided, because of the similarity in virus sequencing, to name it as SARS-CoV-2, and the SARS-CoV, which happened in 2003, as SARS-CoV-1. Our MERS was named according to the origin, which is the Middle East, and that was in 2012. So the name of the virus was given as SARS-CoV-2, and the disease itself is the coronavirus disease 2019. So this is the background of naming how this virus was named. Going back to the coronaviruses, we know bats, they harbor many types of coronaviruses, all the types. So if you look into but usually when the virus jump from bat, there is an intermediate host before they jump to human. What happened in 2002 and 2003? How did the virus, the SARS, ended? Because they were able to identify the intermediate host, which is the civet cat, اللي هي القط البري. That was kept in the wild animal market, and it was prohibited during that time. That's why they were able to stop the transmission to human. In MERS, the intermediate host is found to be the camels, and we still have the cases which is going into human. Likely, the transmission of MERS from human to human is not as bad as what happened with SARS or our COVID-19. Most of the transmission were actually reported as in the nosocomial transmission with hospital outbreak, with also limited community transmission. What's the timeline of events? These cases, as we mentioned, started December 9, but it was reported only on December 30. And then they had to close the seafood market. On January 7, they were able to isolate the virus. And unfortunately, they have the first fatal case a few days later. And then they were able, the good thing that the genetic sequencing of the virus was really shared early with the WHO, and China was actually praised for this. Just a few days later, reported transmission outside China, in Thailand, in Korea, in Japan, and started to spread more locally. So what did the WHO did during that time? On 30th of January, they reported it as public health emergency of international concern. They were reviewing the situation in China and in the other countries where there were some transmission. Almost a month later, they raised the alert to high or very high. And then almost 2 months after, which is in March 11, it was declared as a pandemic. So what happened now with this overall transmission? Up to yesterday, they reported confirmed cases. Confirmed is that means they all has the test confirmed positive by PCR is 2,160,000, and the reported deaths is almost 150,000. Almost every country in the world is affected. I found this really interesting. That was published by Forbes before the outbreak. They were looking into countries who are really good, reported as to be best prepared to face an epidemic, and those who are worst prepared to face an epidemic. If you look here, you will find USA and UK. they were reported as best countries, most prepared to face an epidemic, which is not actually, with the current situation, proved not to be right. So what's happening in our country? Up to the situation is updated every at almost 4 p.m. every day. So the last reported cases is 8,274. That's and the active cases is 6,853. Mecca is the highest reported number, 1,500, followed by Riyadh, Medina, Jeddah, Dammam, Hafuf, Qatif. We have 90, up to today, we have 92 deaths, unfortunately. So that's the report. This is what happened, the action which was taken by our country authorities after the relation to the diagnosis of cases. Sorry, maybe not all of these are clear, but you see that fortunately the action was really taken early compared to other countries. The reported first case was in 2nd of March. And after this, all the intervention measures were taken, including Umrah closure, stopping of schools, even before the WHO reported raised the level into a pandemic. And then we have our international flights suspended, and then the employee were given the leave, and which was extended later on. And then domestic flight were stopped, local transportation was regulated, and curfew were started in certain hour, and then later on extended more. So these are the action which were taken in our country. So taking all of this, there are lots and lots of discussion of how this virus actually is transmitted. Is it really similar to influenza viruses? Is it similar to other viruses, which is not droplet transmission? So every now and then there are studies, either experimental, most of these are actually experimental, which is looking into the mechanism of transmission of this virus. Is it really different? So if you look into the droplets, which is generated by patients who are affected with the SARS-CoV-2, you will find that there are 2 types of droplets. Droplets that is large particles, which is usually more than 5 micron. Those usually travel to within 2 meters, and then they land on surfaces. There are other type of droplets, which is less than 5 micrometer, and these are referred to as aerosols. These one are the one which can stay suspended in air for certain time of period, and that's why you really you need to take highest precautions when you are dealing with these aerosols. So, according to the best evidence available till now, it is droplet transmission. However, with any aerosol generating procedures or therapy, it can become airborne. What are these aerosol generating procedures? These include, it is actually divided into high risk and low risk. High risk is like intubation, extubation, suction, bag and mask ventilation, using BiPAP, CPAP, high flow oxygen, and other procedures like doing MB swab. That's why all MB swabs has to be in negative pressure room, and also doing other procedures like NG tube insertions. The other mode of transmission is contact. We have 2 types of contact, either direct or indirect. Direct means that you get contact with an infected person, so you touch their secretions or excretions. Indirect, if you got contact with contaminated surfaces in the environment where positive patients were there. And this includes all the time the high touch surfaces in hospital, includes stethoscope, the thermometer, and other high touch surfaces in the environment. So this is a video which was published just 2 or 3 days back in the New England Journal of Medicine, demonstrated how droplets can transmit not only during coughing or sneezing, but also during talking or breathing. And they compare this whether a patient wearing a mask or without wearing a mask. So I hope this would be clear.
This is during talking, Dr.
Yes,
Sarah?
talking and in relation to the loudness of voice as well. This is without a mask. And now with a mask, how would this change? So the droplet is much lower than without a mask. Okay, so you hear about, I'm sure you heard about a lot about what R0 or R0, which is called the reproduction, basic reproduction number. That means if a patient is infected with COVID, how many person he can transmit the infection to. So to the best available evidence till now, COVID-19 can infect a range between 1.5 to 3.5%, which is less than compared to seasonal flu and Ebola. MERS, R0 is, as we said, it is not easily transmissible, so it is almost 1 or less than 1 even. For SARS, it ranges from 1 to 2.8. This is completely different if we are talking about airborne transmission, like with the smallpox, where the R0 is 5 to 7. In measles, it's the highest because it's airborne, so it's 12 to 18. So this is just a note about what does the basic reproduction number means when you hear about it. This talks about contamination of the environment by the virus and how long it stays in surfaces. For example, this is an experiment where they test how long it stays on different type of surfaces. If you look into the plastic surfaces, it stays up to 72 hours. If it is a steel, it is a bit shorter, up to 48 hours. Cardboard, it is up to 24 hours. Copper is surfaces is much lower, that is up to 4 hours. How about aerosols? We talked about aerosol, how long it stays if you have them. They reported in this experiment, which was published also in the Journal of Medicine, is to up to 3 hours. It can stay aerosolized. How about asymptomatic transmission? So can you have COVID and you don't know? Would you transmit it to other patients if you don't have symptoms? This study was done in a nursing home in US where they have 23 positive COVID patients. 10 of them were symptomatic and 13, they were not symptomatic. So what happened to those 13 who were not symptomatic? 10 of those, during the next 7 days, they developed symptoms. However, three, they continue to be asymptomatic. So now there's a lots of discussion about asymptomatic transmission, the role they play on transmitting the disease without manifesting symptoms. What can we do about them? How can we prevent them from transmitting infections? Another concern, which we hear it a lot, that this virus will go out when the temperature raised during the summertime. And this study was reported from China in JAMA, and it found this is not likely going to happen because this transmission actually happened in a bath center in China, where a patient who is the index case, he transmitted the infection to all these patients and to the worker who was working in the bath center. The temperature in the bath center was all the time between 25 to 41. And in spite of this, the virus was able to survive and to affect and to transmit to these patients. So the effect of temperature on the virus is really not well established and still need more research. this is if you are talking about, when we are talking about flattening the curve. Did we reach the peak? What does it mean? So this is just explaining what's the difference.
دكتورة سارة بعد إذنك ريهام بالله mute your mic يا ريهام.
Okay.
ريهام mute your mic kindly please. Go ahead دكتورة.
Okay, so this is just, it was just talking about flattening the curve. The main point is that you don't want to overload the healthcare system with lots of sick patients who's requiring admission, requiring ICU bed, requiring ventilation. So slowing it will flatten the curve and allow also the healthcare system to accommodate the number of patients if they don't come in at one time with very limited resources in some hospital. So what do we do in our hospital for patients who are suspected COVID? They usually start with the eyeball nurse, which is placed outside the emergency department before they get in, because you don't want them, you need to catch them early before they get in and before they mix with other patients. So they screen the patients with clinical signs and symptoms. There's a score for adult patients and there's a score for pediatric patients. For pediatrics, fever will take one, cough, either it is a new or worsening cough will take one, shortness of breath, either new or worsening will take one. Adult scoring is different, and also they score adult if they have underlying disease. This was not included, unfortunately, in pediatrics. With the clinical signs and symptoms, they will go back to the risk of exposure. Whether in the last 14 days there is a history of travel abroad, they are living in a high risk areas in Saudi, and we will go to the high risk areas, which is updated frequently in MOH website, or whether this is for MERS or they are working in a healthcare facility. This is of course for adults. This will be scored as a 3. If they have any physical close contact to the confirmed case, they will be scored as 4. So anything that is 4 or higher, the patient will be directed to flu clinic and for assessment and possible screening. So what's the case definition for, this is the updated case definition from MOH, last one. So any patient with acute respiratory illness, sudden onset of at least one of the following: fever, either it is measured or by history, cough or shortness of breath. And in the 14 days, he had history of travel, he visited or being in a resident with high risk areas in the kingdom, or close physical contact with a confirmed case, or if working in a healthcare facility. This requires an epidemiologic link. The other case definition does not require an epidemiologic link. Any admitted adult patient with an explained severe acute respiratory illness, either community-acquired pneumonia or hospital-acquired pneumonia if it is an inpatient. This one is the second case definition. What is the high-risk areas? It is stated here, Riyadh. So we are in high-risk areas, Medina, Mecca, Hafuf, Qatif, Jeddah. These are updated frequently in the MOH website according to the reported case numbers. So this is the case definition that we follow for these patients. What happened when the patient is scored? As we said, the patient will be given a mask, and he will be, if he is really sick, he will go, an adult, he will go to the acute care area. Pediatric, they will usually be directed, they have a different pathway, which they are working on it now, and the patient will be directed to a different area for assessment and single room in pediatric emergency. And then if the score is more than 4, the patient will be directed to the flu clinic, and they will assess him for the case definition. If he meets the suspected case definition, sorry, this is not very clear, he will be swabbed, and a notification form will be filled to notify the MOH. So MOH requires the form to be filled and infection control notification with any case who is suspected. If the patient is stable, he can go home. If he is not stable, he will be admitted to the COVID designed ward, either adult or pediatric. If he is sick, he will go to the ICU. So we talk a lot about definition of close contact. So what is the definition of a close contact? It is a healthcare associated exposure, including providing direct care to COVID-19 patient, working with healthcare worker who is infected with COVID-19, visiting patient, or staying in the same closed environment of a COVID patient, working in as a close proximity or sharing the same classroom environment or office with a COVID patient, traveling together with a COVID patient in any kind of transportation, and of course living in the same household as a COVID-19 patient. So this is a definition of a close contact. The definition in other countries are different, and depending on the distance from the infected case, duration, and so on. So what happens if someone gets COVID? There are different scenarios. Either they don't develop symptoms, and that's what we said, asymptomatic, which can happen up to 30%. They might develop mild to moderate symptoms in 55% of the cases. 10% they develop severe symptoms, and 5% they will require critical care. What happened to those? Well, the outcome, this rate, the reported studies that in those critical cases, unfortunately, who requires the ICU, they reported their outcome is 50% death rate. Those who had severe symptoms is 15% death rate. So these are the systems that can be affected. Every now and then we are getting reports of unusual presentation of COVID infections, atypical presentations. So as we know, it usually affects the lung, leading to pneumonias, progressing to ARDS. It can affect the liver, it can affect the kidney. And it can affect also the intestine, because intestine has the AC2 receptor, which is required for the virus to bind to. The other presentation is brain. They can present with stroke, seizure, mental confusion, encephalitis. There are now recent reports of encephalitis. Also recently, there are reports of Guillain-Barré syndrome in association with COVID. Eye, and there are now recommendations even for ophthalmologists if they want to examine the eyes of suspected COVID, because the virus was isolated from the conjunctiva. It causes usually conjunctivitis. Nose, there are interesting reports of loss of smell in those patients. Also loss of taste in COVID-19 patients. Heart and blood vessels also are affected. They can have microthrombi and clots. They can have also myocarditis. So these are just the stages of inflammation. As you see in uninfected, there are lots of CD4, CD8 cells. Once they have the moderate infection, you will have more of inflammation with tumor necrosis alpha, interleukin 6, and interleukin-10, and increase in the cytokine levels, more of lymphopenia, and you will have also, of course, symptoms at that time with fever, cough, fatigue, and myalgia. If the patient progresses into severe infection, you will have lots of cytokines, which you call cytokine storms. You will have increase in IL-66, high LDH, the D-dimer, procalcitonin, high CRB, high ferritin, and other tumor necrosis factors and other interleukins, with low lymphocytes, of course. With this inflammation, there are different scenarios with the clinical syndromes. They can present with HLH, with hepatosplenomegaly, lymphadenopathy, and they can have the cytokine release syndrome, as we mentioned, with lots of IL elevations and increased liver enzyme, lymphopenia, and cytopenia. So for pediatric cases, we know that the reports in pediatrics is not as much as in adults. So there was really lots of discussion whether our children are less affected, or is it are they different because they have different exposure? Is it because the surveillance definition is different? Only those who are symptomatic are tested. Are we missing them? And there are really lots of discussion with the role they play in transmission of SARS-CoV-2 in the community. As you see here, usually the infection starts in the community with the person-to-person transmission. Those persons, they go back to their family and they can transmit it to high-risk patients, including elderly. Children also, they get exposed. They go to schools and then they transmit the infection between each other, and then they might go back and infect somebody who is really in the community. That's a different category of prenatal transmission, which we'll talk on, and there are some reports of saying that there doesn't transmit to no vertical transmission so far. Even during previous coronavirus outbreak in MERS and SARS, there was less number of children. The other challenge with pediatric cases that they are usually infected with other respiratory viruses. So you might find influenza positive in a suspected patient, RSV positive. They can have mycoplasma as well. And also, it is known that children might have prolonged shedding of viruses. We know this is documented events in all other type of viruses, and it is also more in infants. So if they got infected with COVID, they might have not the usual shedding we see with adults, but it might be prolonged, and that might also play a role in transmission. Of course, most of the reported cases so far, they were either they were picked up because they were screened as part of contact tracing. So majority of reported cases, they have a contact with a confirmed adult case. The question is that, are they really less susceptible? Is it related to immaturity of their respiratory tract system? Does it have to do with the ACE2 inhibitors? Do they have like difference in the function or in the number or the expression of these viruses? Till now, there isn't really strong evidence either to support or to refute this theory. Do they have like non-specific immunity because they are already having lots and exposed to lots of other viral infections and other coronaviruses, which usually cause upper respiratory tract infection and the seasonal one? Is it also because the children, they don't really mount an immune system response, which is less likely to cause cytokine storm? So these are really lots of questions that doesn't have an answer till now. So how about the epidemiology of children? Most of the two well-documented reported series is in China and US. From China, those who are less than 19 years, report said that only 2% of children were affected. If you look at the population of China, 70% of their population is under 19 years of age. In Italy, the report is much lower, 1.2%, and the population of children, the percentage of children in Italian population is only 13%. In Korea, where they do really one of the best countries that do extensive testing, the percentage is higher. Does this has to do with their testing and more testing? Still, the percentage of the children population is 14%. In US, there are different reports ranging from 1.7 to 5%, and children constitute 19% of American population. In Saudi, unfortunately, we don't have data because the report doesn't give the ages of those affected. And it will be really interesting to know because really large population of in our country is in the age group which is less than 18. As we said, most of the children, when they present more than 90%, they are either asymptomatic or mildly or moderately symptomatic. In severe infections, some studies show that it is more in infant. Is it severe in those with underlying condition or other age categories? We need more data in this. This is a recent report published by the CDC MMWR, which is the Mortality and Morbidity Weekly Report. And it reported children who were diagnosed in US during the current epidemic. They have almost 2,500 children diagnosed during this period, from February till 2nd of April. When they looked into their symptoms, and they compared it with adults, 73% of those who had reported symptoms, those only 291, because not all the 2,500, they have documentation of their symptoms. So they analyzed only 291 who really had symptoms. 70% of them, they had upper respiratory tract symptoms, including fever, cough, or shortness of breath. When they compared them to adults, they were less likely to present with fever, less to have cough, and less to have shortness of breath. Some children, they reported, they presented with myalgia, headaches, and diarrhea, but still the percentage are less compared to adult population. What happened to those children? How many of them got hospitalized? How many they required ICU? So majority of the children did not require hospitalization. Those who require hospitalization was in the infant age group, less than 1. And almost 6 patients, they require ICU admission. In the report, most of those who require ICU admission have underlying illness, either asthma, cardiovascular disease, and other chronic conditions. They have, in this series, they have 3 deaths, which is still under investigation. Is COVID the primary cause of death or not? So we don't have lots of data on those 3 deaths which happened in US so far. Another report, which was from China and published in the New England Journal of Medicine, their patients in their series, almost 65%, they presented with pneumonia. The age in the reported series, the median age was 6.7. So the majority in this group were between 9 and 10 years of age.
دكتورة سارة بس في واحد اسمه كامبس ايكون kindly please off your mic. Campus iPhone off your mic. Thank you. Go ahead, Doctor.
Okay. So as we said, this series, 90% they were part of a family cluster. They also presented with cough, pharyngeal erythema, and fever in almost half of the patients. Their X-ray changes, when they looked into it, 1/3 of them, they have ground glass opacity, local patchy shadowing, and bilateral patchy shadowing as well. This was on CT scan imaging of the chest. These are the changes which were observed in those patients. You can see the bilateral infiltrate in the reported cases. And also in this one, it is more of peripheral infiltrate, which is similar to the reported one in adults. Another study also from China, which was published in Pediatrics. This is also one of the biggest number, but when you looked into it, they reported both suspected and confirmed. So suspected, they didn't have really a swab that showed COVID-19. They were just diagnosing clinically based on symptoms and radiologic changes. Those are confirmed are the ones who were analyzed. So they have a percentage of those who were in different age groups. The severity of illness, if you look into it, they classify it into asymptomatic, mild, moderate, severe, and critical illness. The majority were in the mild to moderate age group. This is a classification by severity showing the graph. Most of them, they were mild and moderate category. When they analyzed the severity by age group, they found that infants are more likely to have, compared to other age group, to have severe and critical diseases. Another report, which in JAMA, which looked into the COVID-19 in infants, they reported 9 infants with different age group. The youngest was 1 month and 26 days. Likely, all of them, they did not require intensive care units, and they did not have bad complication. So that's different from the pediatrics report. What happened to neonate and COVID? There are lots of discussion about neonate and COVID. Should we separate the baby from the mother? There are different guidelines. WHO, for example, doesn't support separation, and it encourages as well breastfeeding with precaution. Canadian were more of conservative, like they make it more of the choice of the mother, voluntary separation, what they call it. CDC, American Academy of Pediatrics, and MOH, they advise separation of the baby from infected mother, and breastfeeding, either to utilize the expressed breast milk or to do breastfeeding with clear precaution and education of the mother. So what happened to neonates if they got infected? Till now, there is no report of vertical transmission, no report of isolating COVID from breast milk. This report describes it was published in JAMA Pediatrics, and it describes 33 neonates who were born to COVID-19 positive mothers. What happened to them? It looks that 3 of those neonates, they were positive and they developed symptoms. Whether the symptoms is because of COVID or because of something else, we need more clarification. So those patients, they developed X-ray changes. They have 2 PCR that was positive, and then they were able to clear the virus. This is their course when they have, these are the 3, these are their X-ray changes and the CT scan, and the result of their procalcitonin, the first and second positive swab, and then the third, the clearance of the virus almost at day 9. Second patient, he had also 2 positive swab, both from nasopharynx and anal, and then he was able to clear the virus on day 11. Third patient, he had also positive first and second swab, and he was able to clear the virus by day 15. So all of them, they had favorable outcome, but still the data in neonate is not that much. So how do we diagnose the COVID-19? What is used now is the PCR test. PCR, of course, is very sensitive. However, its sensitivity depends on how good is the sample. So it depends on the sample quality. It depends also on the viral load, which is variable at different stages of the illness. Early on is different from later on, different if the patient is symptomatic rather than asymptomatic. What is used now is that we take both nasopharyngeal and oropharyngeal swab. Both of them are put in the same transport media. The percentage of positivity is of course is higher if we are doing lower respiratory tract specimen like sputum or PL or tracheal aspirate, for example. The test has multiple targets. Some of them are used for screening, which is the E gene that is shared between other beta coronaviruses, and the confirmatory targets, which is the ORF and S gene, which is more specific to the virus. The most important message is that one negative test in a suspected patient doesn't rule it out if you still clinically, if the COVID is still clinically suspected. So it goes back to your risk assessment and the need for to repeat the test depending on your index of suspicion. How about treatment of COVID? There are many treatment trials going on with conflicting results. There are many medications that are tried at different stages of viral entry into the cells. There are ongoing trial on Arbidol, which is an antiviral used for influenza that was used mainly in China and Russia for influenza. There are more trials on chloroquine and hydroxychloroquine, and how do they affect the virus replication. They usually change the pH inside the cell, so the virus will not replicate very well. They also have immune modulatory effect, so they might affect the IL-6 level. Another antiviral is the Calitra, which is a combination of lopinavir, and it inhibits the protease. Another medication which you hear about it in the news is remdesivir, which are many trials now is going on the US on it. It is RNA polymerase inhibitor. It was used initially in Ebola, and now it is being tried as part of ongoing RCTs. Another also promising antiviral is favipiravir, which is used now in Japan and with ongoing RCTs. It was used previously as an anti-influenza medication. Also anti-IL-6, which is tocilizumab. There are ongoing trials to use it. So what about chloroquine and hydroxychloroquine? If you look into their structure, they're almost similar, but they are different in the hydroxyl group. There are many trials which is published using hydroxychloroquine either alone or with azithromycin. Still with some conflicting results because of their study designs. Some of these studies, they don't have a control group. Some of them, they have very low number of patients. Some, they did not report a clinical outcome. They are rather than just reporting the viral load outcome. So we are waiting for more well-designed studies to use these medications. As you know, as you see, there are lots of studies that are now going on, some of them in phase 2, some in phase 4, and with their target dates that we are expecting that the study to be released. So if any of these medications are decided to be used, it should be as part of an RCT and through the MOH and the Saudi FDA. How about vaccines? We have more than 70 vaccines going on in different stages of trials. What is more now is in a stage in phase 1 is almost 2, 3, 4, 5 vaccines that are they already started phase 1 and waiting for their results. About how can you protect yourself? As we said, it's always you have to use the personal protective equipment when you are dealing with patients. As you know, in stable patients, we usually go with droplet and contact precautions. In any aerosol generating procedures, we usually use the airborne in addition to contact precautions, and the patient needs to be in a negative pressure room. So how about universal masking, which is receiving lots of discussion and with some guidelines supporting it and some guidelines they don't advocate it. What is the latest publication from WUHAN, the Saudi CDC? They advise the universal masking for all healthcare worker and inpatient unit, ambulatory unit, and procedural area that they need to wear a face mask at all time. This will help them to reduce the exposure to an asymptomatic infected healthcare worker, which have in US, almost they have more than 100 asymptomatic healthcare workers. So putting a mask will help to reduce the transmission in this category. Also, it will protect healthcare workers if they are dealing with asymptomatic COVID patient who had or those who had mild symptoms who are not yet being diagnosed or suspected. So this is the rationale for universal masking in healthcare settings. WHO give more conservative approach. So they said face masks worn by asymptomatic people are conditionally recommended in severe epidemic or pandemic to reduce the transmission in community. So they are talking about community. They advise use of disposable or surgical mask for those who are symptomatic individual when they are in contact with other individual, which is the basic recommendation. And they said that although there is no evidence that this is effective in reducing transmission, it is more plausible for potential effectiveness. So for you, please take care, especially if you are taking care of COVID patient, make sure that you don't take COVID home. You need to make sure that you change your scrubs before going home. You use shoes that is impermeable. You follow the infection control guidance by appropriate donning and doffing of PPE. You need to wash your hands frequently. You need to avoid touching your face, which is really a big problem. Studies that showed we touch our face almost during a 12-hour shift. Healthcare workers, I'm talking about healthcare workers, the 25 to 40 times, just during a 12-hour shift. Don't wear jewelries, watches. You need to wipe all your belongings, including iPhone, ID badge, glasses, pen, stethoscopes. As we said, you need to change your scrub. You either take it in a washable in the laundry of the hospital or in a separate bag where if you want to wash it at home. At home, when you come in, you need to leave your shoes outside. And the work bag at an entrance if you are not able to disinfect it. You need to wash your hands with soap and water or use alcohol gel if it's available. And if you develop any flu symptoms, you need to report to flu clinic or employee health during working hours. So how can we stop the spread? Nowadays, you need to spread the awareness about the mode of transmission. In this era, I think everybody is responsible. It's not the ID, it's not the infection control. We are all in this together. So feeling a responsibility is really a great thing. So you need to spread the awareness about mode of transmission, use of respiratory etiquette, cleaning the environment, complying with social distancing. What we need in hospital is always to have a high index of suspicion, prompt identification of those cases, isolating them and tracing them, which is the mainstay of really intervention. Also, proper donning and doffing of PPE for all suspected and confirmed cases, frequent hand hygiene. When you try to use your non-dominant hand, because if what we use usually is to touch our eyes, mouth and nose with our dominant hand. So try to use your non-dominant hand for like opening buttons and other things. So if you touch at least your hand, you don't touch it with a contaminated one. And at the end, I hope everybody stays safe and thank you.
يعطيك العافية دكتورة سارة. Thank you very much for very eminent and very inclusive talk. I don't think so it can be done better than this at all. It started from the scratch until the most advanced management and treatment and protections and preventions for this and transmission. So that's one thing. The other thing that I would express my feeling that I'm very happy that and also proud by our trainee, whether they are residents or fellows, by their attending today. And as you know, this is a very important talk and part of the emergency plans in our department. I would apologize that two doctors or whatever they attended by anonymous name or ambiguous name. I rejected them and taken out from the meeting because safety is number one. So please, next time anyone get in, he need to get in by his official name. Otherwise, we will not accept it because, as you know, this is a highly security issues. The other thing that I would like to say back to the COVID-19, as you know, it is very evolving disease. Every day there is something new about not only management, even for transmissions, even how to do the preventions, and everybody is day by day there is something to be discovered. And unfortunately, that when you talk about Dr. Sarah about spreading in pediatric age group, they thought some that it's not actually it is. And I just recall that last week, two of my colleagues they called me. They asked for second opinion in two pediatric nephrology patients. One of them is GN and immune suppression. The other is nephrotic syndrome. And my recommendation to them, number one, is the life is more important than. Please, منى وشيخة بالله سكروا المايك. منى وشيخة سكروا المايك. What I told them, the life is more important than the life of the bodies overall is more important than the life of the kidney. So just to stop the immune suppression and treat whatever they can be treated. And unfortunately, I knew today that both of them, they are critically sick on ventilators. So now the floor is open for a question. So what we want, because you know the attendance is almost 170, so we cannot just let everyone just get in and ask a question. We'll not accept it. Whatever he is, please. If you want a question, raise your hand. Without raising the hand, I apologize to accept a question. So this is very strictly because the number of the people is a lot. Okay, so we'll start by دكتورة شيخة باوزير تفضلي. دكتورة شيخة باوزير تفضلي.
السلام عليكم. دكتور بالنسبة للسامبلز we know one sample.
Okay, go ahead. هذه شيخة اللي تتكلم ولا مين؟
شيخة باوزير.
شيخة شكلك داخلة بتو شو اسمه؟ بتو أكاونت تفضلي. تفضلي شيخة تفضلي.
طيب دكتور بالنسبة للسامبل we take one sample nasopharyngeal swab. Is it enough? Is it enough for COVID roll in or roll out?
No, as we mentioned, the quality of the sample depending on which sample you are taking. In general, lower respiratory tract sample are much better. So getting a sputum or tracheal aspirate or BAL is much better, of course. This is usually done in either adult or in a patient who is in critical care units. But the usual standard sample for patients who are suspected either asymptomatic or mild asymptomatic or moderate asymptomatic in pediatrics is the nasopharyngeal swab. And there are specific training for how to do a nasopharyngeal swab. It's not just sticking a swab in the nose and taking it. No, it has to go back to the posterior pharyngeal wall, rotate it several seconds, and then get it out. So the quality of doing the nasopharyngeal swab really need to be emphasized. That's why we elected that nurses do it, because they undergo specific training for this by infection control. So to eliminate that, is the sample good, the quality and so issue, it has to be standardized.
Okay, دكتورة منى العاصمي تفضلي. بالله after each one get his question, close your mic please.
السلام عليكم، يعطيك العافية دكتورة سارة. Very well.
الله يعافيك.
عندي سؤالين سريعة. الأول can patient present with GI symptoms fever, abdominal pain, diarrhea؟ والسؤال الثاني you talk about how long the virus lasting an object. What about if the object kept in the freezer? How long it will last? شكرا، يعطيك العافية.
الله يعافيك. أهلا وسهلا دكتورة منى. For GI symptoms, yes, as we said in the case series reported by Pedia and the pediatrics, they have, it is less than the percentage reported in adult, but they still can present with the GI symptoms. Unfortunately, it wasn't scored in the new case definition by MOH, but that might be revised because, as you know, there are lots of information and research that is published every day. So it might be revised, but it is part of the presentation. Also, the virus was isolated from stool in different patients, including either by PCR or a viral culture. So that's one thing. For can the viruses stay in freezers? We know that viruses, if you want to keep them alive, you have to keep them at -80 degrees. So the temperature in freezer is usually 2 to 8. I don't think this is enough to keep the virus alive. It might stay on the plastics, which are in the freezer for 72 hours, as documented by the studies. But to last longer than this, it's very questionable.
Okay, so next question to Professor Zamin. تفضلي Prof.
شكرا يا خالد وشكرا سارة. You did an excellent job. Two points. The point number one is this disease, we got to take care of what we call infection control. Honestly, still the treatments on the way. Still, when there is a conflict, result here and there. So I think we cannot lose a healthcare worker, okay, because he's excited and he forget his ABCs of infection control. This is number one. Number two, I need, Sarah, your comments. You know, people in the last 2 days are very much excited about remdesivir. Although I think in the England Journal of Medicine, the Gilad company, they received some criticism that it is not, RCT, and also the whole study was done by the company itself. So I need your comments, Sarah, please.
Yeah, I agree, of course, totally with the Prof. Zamel regarding infection control in these cases and compliance with the precautions. We don't want people to overreact and panic, but we need them to be careful and to follow the appropriate precautions when they do it. Like, for example, when universal masking was advised, you need to make sure that you are doing it appropriately. Like touching the outside of the mask. Outside of the mask was contaminated. Putting the mask down and then putting it again on your face, that's not accepted. So when you do it, you still have your eyes not covered, which is a point of entry of the virus. So we need to be very careful. Sometimes it just gives a false sense of security. That's not right. So when you do mask, you do with all the precautions in addition to the hand hygiene. Your hand is a very important part in the transmission and touching surfaces. So this mask is part of protection, but don't forget the other elements. For remdesivir, as you mentioned, Prof, the study which was published in New England didn't show really a big difference. Yesterday, there were some leaked news through a teleconference. It was done in Chicago, where the study was going on, and they said it was effective. And then when they went to the PI asking for investigation, that was not really an official statement, and they refused to respond to the media. What we are expecting during the next 2 weeks, maybe by end of April, is to have the result of the RCT that is going there. Is it really making a difference? What type of patient was it used? Did they use it in those who are mild moderate? Did they use it in those who are severely ill and in the ICU? So that really need, I don't think the data is strong enough to support it till now. So we need to have the results of the RCT. Hopefully it will be coming soon.
Thank you, Sarah. فهد بشيري تفضل.
السلام عليكم. Thank you دكتورة سارة.
أهلا وسهلا حياك الله.
العافية.
الله يعافيك.
A question regarding what is the current guidelines now we are running in the treatment-wise, potentially either for pediatric age group or adult. What medication we are using as a protocol that we are running for patient that admitted.
Okay. As you know, there are the data are changing almost on a daily basis. Yeah, there was a protocol which was done during when we did our guidelines early in March. This has changed. The WHO they released the protocol for treatment, and then this has changed. The current recommendation is not supporting one versus another, but there are multiple. The one I mentioned, the chloroquine, hydroxychloroquine. Of course, for mode of action, they are similar, but the safety profile is better with hydroxychloroquine. Still, we need to be very careful with their side effects, especially with the cardiac side effect with prolonged QT interval. Some regimen, they use hydroxychloroquine with azithromycin. Some they use the Calitra, which is still studies. There was one release studies RCT, which did not find a difference. Some they use remdesivir. Some center, and there are now also going research on the use of convalescent plasma, getting the plasma from those who recovered and giving it to the patient who are infected. So there are really ongoing trials. The point is that even in the MOH guidelines, the last one which was released, if you decide to use a drug, it has to be part of RCT, and you need to get the agreement of Saudi FDA for doing it, because there is no really standard therapy till now.
طيب يعطيك العافية سارة. طبعا we're running short of time، باقينا بس كم دقيقة ناخذ فيها كم سؤال. I know يعني this topic is putting a lot of questions. So دكتور خالد بن ناصر تفضل.
السلام عليكم. Thank you very much, Dr. Sarah, for this elegant presentation and extensive review. I want to thank Dr. Khalid also for the kind invitation. I have two quick questions.
Yes.
First, I want to ask you, Dr. Sarah, what do you think about the active surveillance being done by the Ministry of Health? What is really the benefit of doing it, especially at this time? And then I have another quick question. Do you think there is any difference in precautions between neonates and older children with COVID-19 if they need intervention in the cath lab? Thank you.
Khalid, obviously I'm very happy Dr. Khalid al-Dhari is attending this meeting, this conference or this seminar. But I'm hearing a lot of noise. أحمد عشري ممكن تسكر السماعة تسكر المايك يا أحمد. يبدو لي نويز جاي من أحمد، وأنا ظنيته صراحة من أبو عبد العزيز خالد الظاهري. شكرا يا خالد. تفضل يا سارة.
طيب. For the first question, active surveillance has been found to be one of the best way to control, and that was actually what was done in South Korea, Singapore, and Germany. So what happened that you don't want to have sustained community transmission. That what happened now in Saudi as a whole, that they have hot spots during and those workers who are really living in very bad condition, very crowded areas. They don't have even the minimum infrastructure to have the good hygienic measures. So this is a very big hub for transmission of any infection, including COVID. So having these hotspots will really be a danger for you, that it will affect your effort to control the infection and mitigate it. I think the best thing in facing pandemic is really to have an active surveillance. The point is that we are limited with the testing we have. It's only till now it is PCR based. It is expensive. You have a problem with availability of the swabs, transport media. Some countries now are really running into an issue with transport media. So it is one of the best methods to control. How can we really implement it actively? Do we have the resources to do it? That really need lots of discussions. Your second question كان عن neonate. Mr. Khalid?
I said, is there any difference in precautions between neonate and older children with COVID-19?
No, it's the same thing. It applies the same thing. If you are doing any aerosols generating procedure, it has to be under airborne precaution. Otherwise, the droplet and contact precaution, like older children.
يعطيكم العافية.
Thank you.
شكرا. خالد الظاهري ما زال يبدو لي الديبارتمنت في بيدياتريك في الجامعة في قلبه.
ما يحتاج.
طيب هالة قاسم، تفضل يا هالة.
Yeah, my questions has been answered partially by Dr. Sarah regarding what medications adopted in the adults, because we hear good news from the recovering patients. So in Saudi Arabia, did they start chloroquine, azithromycin regimen, or Calatra, or what is up to your information? What is their adopted programs by Ministry of Health? Thank you.
Yeah, as I mentioned, most of the regimen in the protocol published by Ministry of Health, they advise the use of hydroxychloroquine. But still, that has to be part of randomized controlled trial registry in the center which were used. They still consider the use of Calitra and other antiviral remdesivir, but as again as part of RCT.
طيب حنقبل بس آخر سؤالين، وعلي عبده بعدين بعده زبيدة، بعدين نعتذر والله من الجميع، يعني جزء كبير رافع يده فاعتذر والله. تفضل يا علي عبده، بعدين بعده زبيدة. تفضل يا علي.
السلام عليكم. Thank you, Prof. Sarah, for this nice presentation, and thanks, Mr. Chairman, for a nice organization. My question, Prof. Sarah, regarding the affecting children with this COVID, really it's not yet clear for me. Is it, if we are talking about brief exposure to coronavirus-like, and there is they have some immunity, the same thing. We were children one day, and we are adult now. We should have some immunity in our circulation. This is the first question. The second question: when we start the treatment, at which stage of the disease? It is in the mild, or in the moderate, or the severe form of the disease for children? Thank you.
For the less affected, the first question, less affection of children, as I mentioned, it is really ongoing research. There is no definite answer for this. Is it because they have less exposure? Is it because they are less going out and getting exposed compared to adult? Is it because they are not traveling as much as adult and so less exposure? Does it have to do with their immunity? It is all hypothesis. There is really nothing that is really proved till now to say that why children are less affected. It might have to do with their maturity of their immune system. It might have to do with their ACE2 inhibitor receptors, either number or function or expression. So it is really ongoing research. So there is really no definite answer for this. Second question, when to start treatment? All the agreement of the patient is asymptomatic not to start treatment. Those who are mildly to moderately symptomatic, the recommendation is to start treatment.
طيب the last question، واعتذر جدا جدا من الناس اللي سالوا في الشات واللي رافعين ايديهم صراحه ويكدوا تكاتش الوقت الحين خلاص اسف على النهايه. اخر سؤال الدكتوره زبيده.
السلام عليكم. Thank you so much, Dr. Sarah. My question regarding the vaccine development. Since SARS-CoV in 2003 and SARS-CoV-2 now, they are very related. Was there any trial to develop vaccine for SARS-CoV initially? And what was the result of those trials, and how does it relate to the vaccine development for SARS-CoV-2 now?
Yeah, as you know, even for MERS-CoV, there were a trial, and they said it might be used now for SARS-CoV-2, but there isn't really a published trial till now to see what even stages of vaccine. We heard about they started the phase 1 trial, which is the safety, but we didn't really have till now enough information to see how much is it really working, what stages of development. The data is really lacking, but it is there, and part of it is also monitored by the WHO. We hope to get the results of these in at least less time compared to other vaccines. As you know, vaccines development isn't an easy job. It takes years usually. The minimum time they take, even if they want really to expedite the process, is 12 to 18 months. So I hope we'll get something, inshallah.
Thank you so much.
طيب يعني لساني عاجز عن الشكر للدكتورة سارة، يعطيها العافية. wonderful talk، وكذلك لجميع الزملاء من استشاريين وفيلوز وريزيدنتس مساعدين على الحضور الرائع. أتوقع يمكن هذه أكبر إيفنت سويناها داخل القسم بحضور يصل إلى 170، وإن شاء الله بإذن الله نلتقي على العلم وعلى continuous of academic activity بإذن الله عز وجل.